does someone survive this? A head-on crash that nearly killed a young woman. Coming up, learn what it takes to repair extreme injuries like hers and see the work it takes to rebuild her body. Good Friday morning. I'm Jessica Lovell, and welcome to the Morning Medical Update. Euna Blythe knows her life is a gift, even if that life isn't completely back to normal just yet. Christina Medina shows us that simply surviving this bad crash required a life flight, surgeries, and a team of medical experts.
You're diagonal, so reaching across and back up.
Movement is important for Euna Blythe. She is grateful she has the ability.
People that has a brain damage usually forgets how to speak, forgets how to use their limbs, or forget the daily routine, but thankfully that didn't ever happen to me.
On November 7th of 2021, the married Kansas couple was driving to Fort Scott when
there's a bridge and there was a black cow standing on the bridge and we ran right into it. We were going 50 miles per hour.
With that impact, Euna suffered severe head trauma.
She's got blood gushing from her. I can see all the little sparkles of diamond glass, all over her face. We didn't even know if she was gonna live. For the first 4, 5, 6 days, it was very unsure if she was gonna survive.
Euna's injuries so severe, she underwent multiple surgeries and procedures to save her. Every bone in her face was broken. She spent 8 days in a coma and 23 days total in the hospital.
I basically knocked on the door of death.
Euna had to relearn everything, how to move, eat, talk, and even breathe on her own.
I could not have hoped for a recovery this remarkable.
This life that I'm living is a gift.
And we are so glad that Euna is joining us here this morning to share more of her story. Good morning, and thank you for joining us, Euna.
Hi, thank you.
And here with me in studio, and to better help us understand what it takes to survive a crash like what we just saw and why a level 1 trauma center really matters to patients. We're joined by experts from our emergency department. Dr. Dennis Allin is an emergency medicine physician who used to lead the emergency department here at the health system. Dr. Allin, we know you go way, way back. How are you?
Yeah. 3 decades or more.
That's all. No big deal, right?
It's been fun.
So you have lots to share and give us some insight into Euna and just these type of accidents that can happen to any of us at any time. Also across from me is Dr. Stephanie Berry. She specializes in acute care surgery. She handles emergency surgeries, trauma surgeries, surgical critical care, you name it. How are you today?
I'm well, thank you.
I know you've been up for a couple of days working hard, so.
Right. So truth being, I'm a little tired today. So
okay, well, thank you for pushing through for us and sharing your insight. Euna, we do want to start with you today. This is such an incredible story, and it's so great to see your recovery. It's been 15 months since that crash. How often are you going to physical therapy?
Once in every week. It used to be 2 times a week, but my therapist agreed that I didn't have to go 2 times a week. So currently I'm visiting my therapist once a week, and it's been going good. She taught me how to tie my shoelaces again.
Well, we're just glad to hear that you're doing so well. It starts with tying the shoelaces, and then before you know it, you're going to be doing all the things that you used to do. And we know that recovery from crashes like this are a very long, grueling process. But I want to know, what are some of the goals? What would you like to really be able to do that you can't do right now?
I've lost pretty much all my muscles that I've built. Unfortunately, I wasn't athletic myself, but I've been running 3 miles every other day, and after that I would just do push-ups and not pull-ups. unfortunately, I couldn't do it before, but I've been working on it, and nobody could foresee that event will happen, and of course I didn't know. And I've pretty much lost everything. And one time I was in rehab in Madonna, a rehabilitation facility, and they gave me a a remote control to press for an emergency, or if I want to be woken up, to help be woken up. And the night before, I dropped that remote control, and I thought, stupid me, I thought that I won't be using it anyway. I don't need it. And guess what? I needed it. And then that following night, I think it was around 2 or 3 in the morning, I woke up from sleep. I needed to go to bathroom, but I could not stand up straight because all my body has lost my muscle, and I could not just stand up with my ab muscle or anything.
Euna? Well, it's like I hear you saying the things that we all think we can just jump up and do in an instant. You know, we take that for granted when something like this happens, and you really have to start from square one to just learn that muscle memory and try to rebuild. And so just to see you today and to see you doing all those exercises, I think you're well on your way. I want to bring in a couple of our docs that we just introduced, Dr. Allin first. So Euna came here on life flight. So what happens when an accident this severe happens? What kind of information are you getting before she would arrive to the ED?
Sure. Yeah, first, I'd just like to say, Euna, congratulations. I mean, it is wonderful to meet you like this, instead of the way we meet most of our trauma patients. When we're looking at life flight or any EMS, we're thinking about resuscitation. We're thinking about, do we have to get ready to do something acutely with the airway? Is the patient breathing okay? Is there bleeding that we need to stop? Do we need extra blood products? We're thinking all those things when we get our information. Some bleeding I can stop. Some bleeding takes the skill of someone like Dr. Berry to stop. So we just have to be, and the other thing we do is to be sure that we have our trauma team down there expeditiously, which they always do, to come in and participate and lead in the care of the patient.
So, Dr. Berry, kind of jump in. How does that communication work? You're coming through the door of our ED, but then you're brought in, and what are you being told, and what's that communication process like?
So, you know, we get notification from our pre-hospital personnel that a patient will be coming, and that goes directly through the emergency department. When that happens, we have a select special criteria by which they would need to then activate the trauma team. And we gather as a multidisciplinary team, and so the surgery department gets called, the emergency medicine department is obviously there, our anesthesia colleagues come, and you have a specialized set of nurses who also care for trauma patients, who kind of all assemble in the emergency department to make sure that we're ready to care for this patient upon arrival. Like Dr. Allin mentioned, that may include needing some blood products. It may include needing to make sure that the airway is protected, and that may mean an endotracheal tube or a breathing tube. Sometimes we have to do additional procedures. There's a lot of diagnostic tests that happen at that time as well. So it's really it's kind of a really big team effort, and we all come together to make sure that that patient gets the right care at the right time.
And that clock is ticking because you know they're going to be arriving at any minute. So you know, when we talk about stabilization, we hear that word a lot. I always say you all are the ones that are depicted in those, you know, primetime medical shows that we see, and you hear the word to stabilize the patient and so on and so forth. But medically speaking, what does truly stabilizing the patient mean, and what are you doing?
So when a trauma patient comes in and we are talking about stabilizing the patient, there's an organized, I like to call it organized chaos that happens in the trauma bay, but it's a kind of an organized dance of making sure that we're prioritizing the things that are being most life-threatening. And so we go through a specific algorithm of, we're going to assess this airway. We're going to assess, are they breathing okay? We're going to assess, you know, Dr. Allin mentioned bleeding. Are they bleeding anywhere that we can see? And we go through that process. We do it the same way every time for every patient, and that helps us to not miss things. And when we say stabilize, we mean if something is not correct or not right when we do that initial examination, if it is life-threatening, we fix it right then and there, sometimes in the emergency department.
That's my next question is, where is this all happening? Right there on the spot?
The initial resuscitation and the initial workup happens right in the emergency department. Sometimes, depending on the injury pattern, those patients may need to go to the operating room. They may need to go to the interventional radiology suite. They may go directly to the surgical ICU. And so there are a lot of different places that the patients may go based on whatever their injury pattern is.
And as we saw and heard, Euna had a serious head injury. At what point would you bring in those other specialties like neurosurgeons, facial surgeons? When did they come in and assess what kind of care needs to happen next?
So they come in as soon as we recognize the injury pattern. So I'm guessing, I don't know that I was involved in Euna's care from the very beginning, but I'm guessing that what happened is that Euna was probably got a breathing tube in the trauma bay because of the severity of her traumatic brain injury, and as long as her blood pressure was stable, meaning it doesn't have to be normal, but in an acceptable range, then she would have gone for a CAT scan. And when we do CAT scans, particularly in patients who come in with traumatic brain injuries and may or may not be able to tell us if things are hurting or that sort of thing, they'll go through a complete scan. So we get kind of head, neck, chest, abdomen, and pelvis to help us to identify additional injuries. And if there's any evidence of facial trauma, they get a facial CT at that time. So when those images are done, we're in that room with the patient. Certainly we rely heavily on our radiology colleagues to read those, but the surgeons are actually pretty good at recognizing the kind of big life-threatening things. And so when we see those things, we automatically start calling our consulting colleagues. So neurosurgery would have been involved in her care probably within the first 30 minutes of her arrival.
So you have all of these disciplines, you know, working together. Dr. Allin, what happens when there's more than one patient like Euna? What happens in those situations, and what's that dance like down there, trying to make sure that everybody is getting the high-level care they need? Well,
I think we have to divide our team, but it's going to be, and we do this not infrequently, we have to divide our team, but it's going to be basically the same structure. And Dr. Barry's team will bring extra people down if that's needed. You know, I think we probably don't go 5 nights without something that's more than one victim coming in, and so we adjust. We'll go to other rooms if we have to, if there's more than 2, and that's why the emergency department's been designed for 30 years now to work off of carts. We don't stock rooms. We stock carts.
Right.
Because we've got 50 rooms.
You got to be mobile.
I can pull a cart to any room. So that's sort of the way we make that work.
So you mentioned 30 years. Let's go back 3 decades, and then let's kind of fill in those gaps. How has the ED department here and really just everywhere, how has it evolved? What has it learned to make sure that they're delivering the best care as time has progressed?
Right. Well, I think the main, when you talk about trauma, it's changed entirely. Because as recently as 1997, I was on the committee that wrote the first trauma system for the state of Kansas. And it just started building from there. But I can tell you before that, it was not an organized system. It was a surgeon who said, yeah, I'll come down, you know, if I'm available. And luckily at the time, our emergency department was seeing about 22,000 patients a year, and we see 3 times that now. So we probably got away with it somehow by numbers, but our system now is and the resources that it has is so much better than it was when I started here. It's just night and day.
You've watched it change over the decades. I'd say years, but it's decades.
Oh my goodness. And it
So I want to talk, another discipline is anesthesiology. What role does that play? And the difference between being under anesthesia, we think of that for medical procedures that are routine and certainly planned, unlike this situation. What's the difference between that and perhaps like being in a medically induced coma, and who is responsible for handling all that?
Sure. So our anesthesia colleagues actually come to all of our trauma activations. We're kind of fortunate in that sense. And so if we have a difficult airway, for example, our ED colleagues in general do all of the intubations and the airways for us. But there are times when those things are really, really challenging. And so we try to have all the experts in the room at the same time. And that includes our anesthesia colleagues, so they come. They also are there because anytime a patient needs to go directly from the trauma bay to the operating room, they're there to help make sure, one, that they know that that's happening and that they're ready to go, they have a room ready, and two, can kind of help us get the patient in and take over that resuscitation as we roll to the operating room. In our particular surgical ICU, it is staffed by surgical intensivists. So everyone on our trauma panel, all 9 of the surgeons who take trauma call here, are dual board certified in general surgery and surgical critical care, which means we can manage the patients from the beginning of their stay throughout the continuum. And so when we talk about a medically induced coma, it's not about who specifically is doing that, it's really more about the medicine and that sort of stuff that we're using. When a patient has a severe traumatic brain injury, one of the things that is important is to try to calm the brain and allow it to heal. And so we put patients in what we call a medically induced coma, and really what that means is they're on a lot of medications to keep them sedated, so that their body is not trying to work as hard.
So it's just resting, so you can do your work.
We want them to rest. Now, we do need to wake them up frequently to assess where that neurologic function is, but for the most part, we kind of let them rest, and we take over from a critical care perspective of the major things. So we are helping them to breathe with a breathing machine. We are oftentimes feeding them with tube feeds or a tube through the nose that will allow them to get nutrition that way. And we're giving them sedation to try to keep them calm. Because the more excited that they get, the more brain activity that there is. And we're trying to avoid swelling, we're trying to avoid low blood pressures, we're trying to avoid low oxygen levels. Those are the big things in the early phases of a traumatic brain injury.
And really everything that we're talking about right here in all of these disciplines, that's why I brought up anesthesiology, is because it really helps make up and explain why we are a level 1 trauma center. Now, we hear that, but I really want you to help our viewers understand what that means and how it really, really matters to patients that show up at our doors. And Dr. Allin, I'll let you start.
Okay, all right. Well, I think that it begins with the skill of the people that come to work in this health system. But I have to tell you, to me, it's comparable to what we see in high-level athletics, that you put a great bunch of people together, but if you don't give them a structure and resources and feedback and support, it won't work. They won't play. The team won't function. So I think that's what a level 1 is about. It's about providing that structure and support so that the team can actually function at a level that can save people's lives that are very seriously injured.
So when you're communicating though with Life Flight or EMS, how it would make sense that anybody would want to come to a level 1, but that doesn't make, that's not always going to be possible. So what are those conversations like, and how do they know this is the type of injury that needs to be here at the health system?
Right, and I've been in EMS, matter of fact, longer than I've been here, and we really work, and Dr. Barry's team works with EMS to lay out what are our criteria, what are the trauma criteria to come to a level 1, because a lot of of areas of the country have found that if what you just do is take everybody to the level 1, you can overwhelm it. So we have our criteria, and EMS knows what that criteria is, and they will activate that they're going to a trauma center based on that criteria, and that happens all over the city.
Yeah, and at city and state level, you're working together. Dr. Berry, we're level 1 trauma, that's got your name written all over it. Tell us a little bit about why that matters.
So when I think about level 1 trauma center and what that means to me, it means that, so he talked about being athletes and putting this team together and having structure and support around it. And the American College of Surgeons really provides that structure and support. There are a kind of concrete list of criteria that we abide by. And it includes things like education, it includes things like research, it includes things like making sure we have all of the subspecialties available to us so that we can take care of any patient that comes through that door, no matter the severity of injury. And so the idea behind a trauma system and having different levels of trauma centers is, like Dr. Allin said, we can't take everybody to the level 1 trauma center because they will get overwhelmed. And the goal is to get the right patients to the right place at the right time. We do know that for the severely injured patient, the further you live from a level 1 trauma center, the higher the mortality rates. And so this level of expertise and this team that comes together to provide expeditious care really does improve outcomes. And so I think to me, that's what it really means for us to have a level 1 trauma center, and for the community to be aware of that, I think is fantastic. At the University of Kansas, we've been a level 1 trauma center since 2000. And so we have a lot of experience with that, and our team has been working together for a really long time. I haven't been here as long as Dr. Allin, but I've been here over 10 years, and we've worked really hard to continue to hone our skill, and we still do that every day.
And Euna is living proof of that. Truly living proof of that. Euna, I want to ask you just what it's been like to have just support from family and community. I think your family came over from overseas. Is that what I hear?
Yes, they did.
What did that mean to you?
I didn't know they came. Apparently, my husband Nelson called my family and said, "You need to come here right now." And no questions asked, nothing. He just said, "Just come over here right now." And my parents knew something was seriously wrong. And they came, and my sister came too later on, and my family here in States says that I woke up from my coma a day after my sister arrived in the States, which I have no memory on that, but that's what it was. And I don't remember my father or my sister. But one thing I remember is that I woke up from a hospital bed, and my mother was crying on my chest. And I was at that point I was clueless, morbidly clueless, and I thought, "Oh, why is mom crying? There's nothing to cry about," which was
Well, Euna, what a sweet story. I mean, your parents are like every parent. They rush to be by your side. They know that they're needed to be with their girl, and for you to wake with your mom by your side, I'm sure surprising and shocking, but had to be comforting as well. So thank you for sharing that story. If you have any questions for Euna or our doctors, go ahead and send those in to the chat on YouTube, Facebook, or tweet us. The information is right there on your screen. But let's get a quick check on our COVID count with Dr. Hawkinson.
Yeah.
Good morning. How are you?
Hi, I'm good.
It's Friday. Are you so glad, or is it just me?
Yeah, I'm glad. I don't have to work this weekend.
There you go.
But next weekend I will. So.
I gave you the weekend off.
That's right. Right now in the hospital, 28 total infections, but the active infections haven't gone up, just a little bit. 15 total active infections, and then 3 in the ICU and 0 on the ventilator as well.
Okay, there's a headline I want you to chime in on. There's a bunch of evidence showing the COVID vaccines are safe, but one analysis out of Florida showed the vaccines caused an increased cardiac risk for young men. Now reporters have seen the original drafts of that analysis, and they show that the Florida Surgeon General tweaked the study several different times. The Surgeon General said changes are a normal part of scientific studies. Help us understand what sort that out for us.
Yeah, you know, I was able to kind of read some transcripts of an interview when he was asked about that, and also have seen some other interviews with this Surgeon General since his appointment, because I know there was some scrutiny in that appointment. So in general, you know, if the conclusion of that statement and the study about cardiac risk were true, it certainly would have been a huge revelation. But these records actually show how science is not done, and we've talked about the proper ways to do science and evidence-based medicine here on this show, and then also with Dr. Stites on his show. So overall, when you go through this study, there were overall kind of 6 drafts looking at all of these data and trying to assimilate and post on those results, and they had different conclusions. So there were, again, several drafts. Initially, they concluded no increased risk of death after the vaccination, and then the subsequent drafts, you had changes looking at the risk period and the control period, removing analysis about the risk of death after COVID, in adjusting sensitivity, all of those things which overall, you know, don't make those final conclusions necessarily accurate. It doesn't really seem like this was truly peer-reviewed, and when you go through the actual evidence, it doesn't really support that. We know that various other studies, in fact, there was a peer-reviewed one in the New England Journal of Medicine just recently showing absolutely no increased cardiovascular events from vaccination. So overall, understanding this particular appointee, having looked at interviews and read transcripts, it really seems like this is more political. But unfortunately, we have seen a lot of divisiveness and political divide about the pandemic in general. This is just one more of those aspects that we can understand and take in.
All right, thanks for explaining that, Doc Hawk. Thanks so much. Any reporters with us today? Let's get to community questions, and I know we got to get going here, but I do have to ask one from Tina. She says, how often do trauma docs keep up with patients after they leave the ED or the ICU? I know things are fast and furious for you all, but I mean, there must be cases that that stick out for you, right?
Sure. So in general, trauma surgeons will follow the care of the patient throughout the hospital stay. So we see them in the emergency department, we take care of them in the intensive care unit, we take care of them on the floor, and then they go on to rehab or other things. But there are those patients that just stick with you. I have a patient who I took care of as a fellow in 2010, and she came to my baby shower.
Love it.
And wrote a very nice letter to my unborn child that I'll be able to give to him on his 16th birthday. So there are those patients that just stick with you. And I just want to comment, I had mentioned that I wasn't sure if I took care of Euna, but the more I see the pictures and I hear more about her story in retrospect, there's no question that I helped take care of her in the ICU. And Euna, it's so good to see you doing so well, and your recovery has been remarkable, and I just want to encourage you to keep up the great work.
Awesome. And this is why you do what you do, right? That letter to your baby, that's a very good example. Dr. Allin, just same question. Do you have people that you see or that they keep in touch with you, or that at least just maybe you just think about driving down the road? Oh yeah, I mean, and mainly because we deal with both the trauma and the medical side, but I think the ones that have probably stuck with me the most and through time have been sick children. To be honest with you, because I don't think there's anything more satisfying than a child is really, really sick, and you're able to participate in a team effort to give that child back to their parents. Yeah. Having 3 that are grown and out of the house, I just don't think there's anything better than that. Well said. Jeremy wants to know, Euna, what part of your rehab and recovery are you most proud of? Anything that you're just...
All of it.
All of it. That's a really good answer. All of it. Absolutely. Any and all of it. So So you're still back at it, doing it once a week, but you went down from 2 days because you've been doing so good at it. So thanks for keeping that up. I want to get our takeaways today. And Euna, you had told us back after you were out of the hospital that you wish that you could take out an ad in the paper to publicly thank the medical teams that took care of you. And you have a chance now. I want to let you just share anything you'd like to tell the teams here at the health system.
All right, thank you very much. It's so much of a debt for me because so many people have helped me for me to get over with it, like monetarily, of course, and also mentally. So I won't be able to pay it back. I don't think that was a good expression, but I am very thankful for all my neighbors, my family, of course, and my therapists. I cannot thank them enough. So I just want to reach them out, like a local newspaper, thanking them how much they helped me to get back on my 2 feet. So that would be great.
Oh, Euna, no debt needed. You are debt-free from the health system, and we appreciate you. And I'm speaking for them that it is their pleasure. Just seeing you doing well, that's all they need. So we appreciate you, and we just thank you for being you and being well and sharing your story. So thank you. Dr. Berry, just what's the takeaway today?
Well, I think that I'm so grateful to have been here today to see Euna and her recovery and how great she's doing, and that's really quite amazing. But my big takeaway would be unintentional injury is the leading cause of death for people aged 1 through 44, and it's the number 3 leading cause of death for all age groups. And so it's not really a matter of if, but when you're going to need a trauma center. And so just know that we are here, we are prepared, and we are always on the ready to take care of patients.
Yep, she's been up the last 2 days, so go get some rest. Promise?
Promise.
Okay, Dr. Allin, takeaway today, what is it?
Well, I hate to follow her, but
She's tough. She's a tough follow. Sorry to make you do it.
She's a tough follow. I guess in speaking historically, I would like to recognize the health system when it wasn't, before it was called the health system. I think I've had a coat that's had like 4 different things on it, because this took a recognition and a commitment to do this, and it just didn't happen. It happened through people deciding it was going to happen, and I think that. One thing that's been here almost as long as I have is some of the people that are in the C-suite of this health system, and I think I tell people to come to interview that, and this is honestly how I feel, that our administration doesn't work by a checkbook, they work by a compass, and they know what they want to do, they know what's important to do, and they do it, and I think I really commend them for that.
Well, and thank you for your leadership through the years as well. Thank you both for the work you do for our patients. And thank you for being here. Dr. Hawkinson, I got to make you follow all these people. I don't know what you're going to do.
Yeah, well, it's easy because I'll just piggyback on top of both of those comments, really. What we do practice here at the health system is evidence-based medicine. That includes, the research, but also that clinical practice and best practices for that. And that did not occur at one point in time. It occurred through many years and many investigations on how to do best practice. You have seen this with Dr. Berry, as she talked about, and Dr. Allin and his practice in the emergency department. That is what we continue to offer here, and we will continue to grow and evolve as new research and techniques become available as well.
Fantastic. Way to wrap up the Friday. Thanks so much. And thanks to, again, our guests and all of our viewers. We will see you here next week. Coming up Monday on the Morning Medical Update, an avid biker learns hours in the sun has taken a toll. Aggressive skin cancer spread to Mark Morgan's lymph nodes. I'm Jessica Lovell on the next Morning Medical Update, the treatment that turned a poor prognosis into survival. Plus, we'll test your sunscreen knowledge Monday at 8 a.m.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stein's podcast. Now, everywhere podcasts are available.